afternoon. Just we are, I think, in between the lunch and of course, after the lifestyle talk, maybe many of you will decide something else. And we are here to have a session on intelligent healthcare. I don't know what is intelligent healthcare now, after listening the talk from Dr. Paul. Is it the preventive care or is it the tech? And the CAHOCON this year have got both touch and tech. So if the preventive healthcare is the touch, the tech is also there to give you some kind of intelligent, innovative healthcare system. With me today, the co-moderator is nobody than Dr. Venkat Phanidhar, one of the, you can say, a very famous entrepreneur. Venkat Phanidhar is the founder and chief mentor of Sasta Healthcare. And I would like to give him the opportunity to greet all the speakers and then start the session. Venkat sir.
First of all, thank you so much for being here, because I was expecting everybody will move out of this and we have to continue this session in the lunch hall rather than in this. So my dear friends, today we have this topic, intelligent healthcare systems, which sounds very futuristic, but occasionally a little intimidating as well. Friends, we are living in a healthcare system today. We have reached a stage where our systems know much more than we know. And also, they alert us sometimes that we know more than you, better listen to us. Intelligence has overtaken people intelligence actually. The system intelligence has overtaken the people processes. In simple words, if you want to say, processes by people is like wife, only data is available. And system-driven intelligence is like mother-in-law. She predicts, she alerts, and she'll ensure that the action is also taken. So my dear friends, today we are all here to listen to some of distinguished guests who are into, bringing in technologies in healthcare. My dear friends, we are not just here to listen from you what technology is delivering, but want to know whether this technology that you are bringing into healthcare is really making us to take right actions every time that we need them. Okay? And thank you so much for being here with us today. And I request the first speaker, Soujanya Narala, to speak on From Dependency to Enforcement, Designing Systems that Ensure Action.
Good afternoon, everyone. From dependency to enforcement. How do we make systems enforce actions at the right time for the right things? That is what I am going to cover about. We Shivam, a hospital management software company with experience over 1,000+ installations of all sizes, including premium clients like Breach Candy, Sayadri, the Manipal Group, Ujala Signals, the General Atlantic, Dr. Mehta's Chennai. One common thing what we always encountered, irrespective of the size of the hospital, are the few of the common operational problems across all the hospitals. I know when I put up this slide, all the operational problems you see here sounds very common. Most of the hospital owners, the management teams might also correlate that, yes, this is my problem. Maybe everything that's showing up on the screen, all are my problems. Right? We all know, as basic as this sound, these problems exist in every size of the hospital, small to big, and even the enterprise setups. We did a survey for about 30 hospitals from our client network, and we came up with this case study, which says even a 30 beds hospital lose 14 to 22 lakhs per annum from these some of the known sources like expired stocks, excess stocks, missing stocks, unpaid dues. So bigger size setups even lose in crores. While we were analyzing the root cause of these problems and trying to understand how do we solve this, that is where we encountered that there are two problems with it. One, the software problems, which says the visibility of data is poor in the systems. Like just now we heard that today the data is everything, systems know more than the human beings, but the poor systems where there is no real-time visibility and the management depending on the teams for legacy reports and dashboards. Also, very hard to derive actionables even if the data is available. These were the system problems which were supposed to be solved. And then there comes the people problems. Even if we have the data, most of the hospitals today have some or the other softwares. They have some kind of reporting, maybe scattered towards the departments, not really efficient enough in deriving the actionables, but some kind of reports will still be available. Still, how do we make staff act on it has been a real challenge. Usually, what happens? For every action that needs to be done, what management does? Follow-ups, over follow-ups. They keep discussing, but things doesn't happen. And it ends up in review meetings, things not happen, and we almost get to hear, sorry, sir. So that is the common people problem, which is also supposed to be solved to come over these operational challenges. Most of the staff is efficient, but still they fail with executions. So we realized solving any one of this problem, either the software problem or people problem, doesn't solve these operational challenges. Both needs to be solved together. And yes, it is possible by technology. The technology can solve it. Let's see how. You see a ICU monitor on your screen? What is ICU monitor? It basically puts a single screen showing all the key vitals of the patients with all alarms and beeps for critical value alerts, right? So one single screen is showing all the alerts which can assess your patient's health. Now, let's just think if at all this monitor was not available and we are relying on 10 different monitors to get these vitals of the patient. How difficult it would have been, right? I think ICUs would never operate in that case. Same way, we thought and we applied this idea to create control tasks. What are control tasks? We introduced these control tasks, one single screen systems, which are mounted as TVs on the management rooms, which shows live streaming of hospital operations data with unlimited drill clickable to the lower level data possible. We also designed the yellows and reds, which actually talks about the real actionables for the moment. For example, let's see. There's a stock value which shows what is the total stock value holding of the hospital, and entire data is online, with which we were trying to solve the visibility problem. So we provided everything that is required on one screen, And when you click on this stock value as an example, you see the health of your stock in your hospital, which says what is your overstocking, what is your deficiencies in the stocks. Along with that, it is also showing you where your stock is actually located, in which store, how much stock. When you again drill back, it will also give you item-wise information of in which store what items are available in which quantity. With all these control tasks and technologies, we have solved the system problem. But did the problem solve? No, because the second one was still there. Even this control task couldn't solve the problem, as even with the perfect visibility, the problems were still pending. Because people still had to act, and we all know people don't always act on a timely manner. Then the actual problem we understood was data was visible, but the action was optional, which led to a breakthrough idea. We discussed among ourselves, came up with an idea, and we asked questions to ourselves. What if we design systems which itself enforces the action? And what if the process is not dependent on the people or human choice? And what if the software ensures compliance even before the damage happens? This thought led to our initiative, Make Money, Save Money. I'll just take 2 minutes to take you through a case study. That is the near expiry medicines of a pharmacy, which is a favorite topic of any of the hospitals, because that is where your actual losses creep in. So to avoid this, how to solve the near expiry problem, we came up with the control task, putting up the data on the screen, showing department-wise the bucketing of every items, how many stocks pending were expired, and also the near expiry buckets. Click, it is also showing you what items are supposed to be expired and which are supposed to be written. Here, even after data was available, the people action was optional. So that is where we came up to solve the people problem. We came up with a control which says, we redesigned the entire process basically, disrupting the back-end operations of the procurement. We took these actionable items from the control towers and plugged them back into the transactions as a controls. To disrupt the back-end of operations, user cannot make a GRN or a PO unless the expired stock is returned.
Can you make
that
it
is,
faster, ma'am?
the system forces user to return the stock before proceeding with GRN or PO. Once the returns are done, automatically the PO and GRN process resumes. What happened next? With these controls in place, no follow-ups, no reminders, people started acting automatically. As system took over the control, this one control enabled, your stocks will never expire ever again. Throughout the process, one golden rule we followed, that we never disrupt the patient care. They only enforce the administrative compliance. Patient services always continue. This is what something that has been taken care very carefully. So understanding that this concept works, we have created many controls in every department wherever we have seen the scope that operations can be controlled via compliances. Final thought, I want you guys to leave with this. Does your system ensures the right action happens at the right time? It is not the amount of softwares we have, but do we have the intelligent softwares which ensures compliance as a mandate but not on a human choice? Thank you.
Thank you, ma'am, for your thoughtful talk. Actually, the technology has to come for inventory management more and more, because more complicated inventory system is now being used by most of the hospital, not only in our country, across the world. With that, I think Mr. Phanidhar sir will introduce the next speaker.
That is very insightful, Soujanya, and we face as administrators in our, logistic support is very important, and stocking processes, etc. Now I call upon Dr. Vandita Gupta, who is the Senior Vice President, Advanced Therapies and Diagnostics Imaging, Siemens Healthcare, Health Engineers, Healthineers, right? That's how you, okay. So, the topic is what CEOs want from MedTech: proof, performance, and predictability. There's one more P also you are missing. If it is a CEO, definitely we'll also look for profitability. Okay? So if you can add upon that, it would be great, and we look forward for your presentation. There is a human
Hello.
error there.
Hello. Yeah, that's a good challenge to start with, profitability. Good afternoon, everyone. We've lost some of you to lunch, but I think that's a valid reason. Thank you to the organizers to have us here, voice our thoughts. August audience, a great good afternoon to you. It's not every day that I'm in a room sharing with many healthcare leaders. Thank you. So it's not every day that I'm in the same room sharing space with healthcare leaders from the country, industry experts.
Can you keep the mic a little closer?
Am I now audible? Yes, show of hands, audible? Great, thanks. That means I have the audience with me. Okay, great. So, what I was saying is, since so many of you are in the room, let me begin with a thank you, and let me begin with a compliment. Because there's so much work behind the scenes that many of you would have put in to see where we see Indian healthcare with a paradigm growth in the last 5 years. So that's a huge compliment to all the leaders sitting here, and I would say a big shout out to all of you. But while I say that, I'm also going to pose some uncomfortable questions. Yes, we've added access, we've added more beds, we've moved to telehealth about 38 times more than where we were about 6 years ago during the COVID times. But we do know that patients are still waiting. Care does not happen on time all the time. There are huge discrepancies on access still, even in the top 20 cities of the country. Yes, we've invested in technology as hospitals. We've got the best clinical teams, and that's a commitment data tells us from more than 60% hospitals in the country. But still, there are inefficiencies that we have. There are only about 5 or 8% hospitals in the country that today have institutionalized monitoring quality and monitoring outcomes. Yes, we've invested in digital, and we've been hearing that all of through 2 days in this meeting. But what we also know is that there are less than 5% hospitals today that are really ready to adopt technology and digital to the far end and really meet ends meet. And while all of this is happening, it's interesting to note that while we have the huge talent exodus that is happening outside India, the ones who are still here existing with us, are they ready to really move with a change on patient access, on operational performance, on efficiency, on digital innovation with the way the healthcare leaders are driving today? Probably not, right? And these are a few uncomfortable truths that happen between what we plan as strategy inside hospitals and how we execute it. So while we talk about all of this, I think one thing all of you sitting in the room will agree with me is that yes, there are investments that are happening on digital, on AI. We want the best of equipments and care models with us. But one thing that we're not able to solve for is, I'll ask a few questions. And please give me a show of hands. How many of you believe that while you would have the best clinician sitting in your hospital, when the patient would move outside the building, he would get the same standard of care outside? Show of hands. Probably not many. How many of you would think in a hospital you would have patient flow within the hospital outside up till survivorship fully mapped out very clearly. While many of you here would be thinking that yes, it happens, but I would doubt if you would say that it happens consistently all the time. So what do we do? When would consistency happen? How would it happen? And who will make it happen? Will it happen in a span of 1 year? Probably not. Who can make it happen? Can the hospitals make it happen on their own? Probably they'll need partnerships. And when they need these engagement models, how will it happen? Probably new operation models, new ways of engagement is something that would be able to define it forward. And that's exactly what I want to speak about today. Let's look at a few real case examples from across the globe on how hospital peers actually decided to tackle these challenges end to end. So I'll pick up a disease area for an example. Let's take stroke. We know in India, more than 90% of the patients of stroke do not make it to the hospital within the golden hour. And this was a similar similar challenge that Spain had. I'll talk about this. Here, the hospitals and the C-suite was not talking to their partners, to their vendors, only on technology. Yes, they wanted to get the best machines in. Yes, they wanted the best clinical teams in. But what they were talking to vendors, or I would start using the word engagement partners here, was end outcomes. For example, on stroke, they said, yes, you give us the machines, but what I want to see is how do I get a 30% better door-to-needle time? How do I reduce the patient length of stay after the patient has been intervened on stroke? And that is where efficiency and, to your question, profitability for hospitals starts to go up along with the quality of care. So I'll take this very quick example, and maybe in interest of time, I will skip others, but I'm happy to talk about it later. This is an example from a hospital in Spain, where they said that we want to cater stroke end to end. And how do we reduce that time? They did a consortium where they came into partnership with Medtronic, with Siemens, and with a few such partners, where they were able to bring in a technology in which they were able to diagnose the patient, put in the right software so that as soon as the patient is out there in the community, diagnosed with the first symptoms and signs of stroke, is subjected to the right diagnostics, and the paramedic is speaking right away to the doctor while still in the community. So that by the time the patient enters the hospital, he doesn't go to the ER, he doesn't go to the CT room or the lab, he goes straight to the cath lab for the intervention if needed. And then work around all the other mechanisms which could be around patient education, around staff trainings, around other workflows that would make this happen. What Siemens was able to achieve along with this hospital was put the skin in the game and said, we're going to charge you for the equipment and the partnership later. Let's get the outcomes in first. And that's what we see on this slide, about 30% reduction in the door-to-needle time. In the interest of time, I'm going to skip these slides and I'm just going to quickly conclude. We've got about 250 examples like this with who's who of healthcare systems who've engaged into partnerships with us, where we've worked with hospitals, not just on technology, but ensuring that we co-work with them on a long-term basis, having our skin in the game, and ensuring that we work on financial stability, improving access outcomes, operational performance, and much more for hospitals. So this is going to be my concluding remark, that we've evolved into healthcare systems which are not just about technology, which are not just about digital, which are not just about operational efficiency, but we're moving towards models which are designed to be holistic. They're designed to be relational. Our technologies, digital can be global, but healthcare has to be driven locally, and partnerships are the way to move forward. Thank you.
Excellent deliberation, Dr. Vandita Gupta. I mean, Siemens is known for its technological evolutions in imaging techniques. That includes even nuclear medicine. And many of the radiotherapy units across the world are highly supported by intelligent healthcare system by Siemens. So no doubt it will be definitely apt to be told that intelligent healthcare system is going to play a major role in imaging medicine in the coming days. So I would like to now introduce my extreme right speaker, Dr. Arun V. Joy. Dr. Arun is a pulmonologist by practice, and he is also specialist in allergology as well as sleep medicine, which is very important in today's time. The practice of sleep medicine has gone up to a very different scale last 10 years' time. And there we are going to hear from him. He will talk on stethoscope to smartphones, bridging the clinician tech gap. So please, Dr. Arun.
Thank you for the kind introduction. Good afternoon all. So my topic for the 10-minute talk will be stethoscopes to smartphones, bridging the clinician tech gap. So I was fortunate, and most of the clinicians sitting here will be fortunate enough to start our journey, medical journey, with the basic equipments, the stethoscope, and with our clinical skills and our clinical intuition to get a right diagnosis for a right patient. But now, when I started practicing 10 years back, it all became from paper to digital. And what we actually need to impose is a proper integration between, a balanced integration between the clinical intuitions and the digital healthcare. So it all happened from the base analog to digital, and now it is intelligent. So the artificial intelligence has made a huge leap in the medical field, and from the age-old stethoscope, now it's a digital stethoscope where I can monitor a patient's respiratory system, the adventitious sounds, whether it's a wheeze or a crepitations, from hundreds of kilometers using my mobile phone with a digital stethoscope. And from the paper records to EMR and now AI chatbots which help you in transcribing your IP and OP notes. And from the pure clinical judgment by clinical examination and from the patient history to AI-assisted decisions, which actually improves the patient's outcome. So actually we carry more computing power in our pockets than the entire ICUs of the past. Yet, we know many clinicians still rely on the traditional tools. The technology exists, but adoption gap still persists. Technology is advancing faster than the clinical integration. The technology and the clinician gap is still real. Why? Because there's a huge data overload, poor usability, clinician frustration, definitely. We are coming from rural Kerala, a hospital, but the we are up to the mark of any other hospital in the metros. But we see a clinical frustration when the technology is advancing. The clinicians find it difficult to adapt with the system. Lack of training and awareness is another big gap. The trust deficit in AI, still we find that there is a huge trust deficit in AI. The diagnosis may not be right. The treatment I'm going to propose may not be right. So the trust deficit in AI is another big thing. The workflow disruption, cost and accessibility issues are also a big thing in a country like India. So why the gap matters? So there is definitely a clinician to technology gap. When the gap increases, actually that delays the diagnosis of a patient. You can miss the early warning signs which the patient demonstrates in your OP or an inpatient scenario. Inefficient workflows can happen and easily burning out from the clinician side. For a simple example, we have now the system of digital inhaler compliance monitoring system, whether the asthma patient is compliant or adherent to a therapy. We can monitor that with our mobile phone the clinician is having. If the clinician is able to monitor the patient's compliance with the therapy, we can actually prevent the exacerbation, asthma exacerbation, which actually increases the healthcare cost of the patient. But the other way, if you are not monitoring that closely or properly, then that actually increases the risk of a preventable exacerbation. So how do we build the bridge? To prevent the gap or to bridge the gap between the technology and the clinician. First and foremost, the training. So training is the first important thing to bridge the gap between technology and the clinician side. Digital literacy should start from the MBBS days itself. Design. The clinician-friendly interfaces is a must. You should not be too much complicated when you are presenting the technology to the clinician. And the clinician leadership in design should be there. A pediatrician who writes an EMR, it's entirely different from a pulmonologist who writes the EMR. So both the departments, it's entirely different to have a different interfaces or different set of clinical questions that should be asked and entered in the EMR. So the design should be clinician or the department based. Validation. The evidence-based tool should be used to validate the data, and there should be a seamless EMR workflow integration. And last but not the least, the mindset of the clinician should change. From resisting the technology, it should be a collaboration and adopting the technology. So that is the most important thing in this. Indian perspective, we should always consider that there is a huge patient load. We should consider how your EMR or the technology is going to help those doctors who see 100 to 150 patients a day in a 6 to 8 hour shift. And there is definitely a rural and urban divide is there. Limited specialists is one thing which we should consider when we consider the perspective in India. But even when we consider all these backlogs, in India, the technology can enable task shifting, improve primary care diagnostics, and strengthen the telemedicine networks. Now, the actual topic was smartphones to the, it's a new stethoscope. Actually, the smartphones with an AI can be considered as a new stethoscope. What note can be done with your mobile phone? Your mobile phone is a multifunctional, having a real-time connectivity with connected devices. Like I can connect a spirometer, my Pheno devices, my FOT devices to my mobile phone. I can connect an ultrasound probe to my mobile phone, and my mobile phone can act as a digital stethoscope. But all this technology putting there, empathy should come first and technology should be second. When a patient walks into my OP, I should be looking at their eyes first rather than scribing on my EMR. And the technology should be invisible, care should be visible to the patient. Then only this technology and clinician gap will come down. I'll end my talk with the recent published article in JAMA, The Lost Aura of Physician in the Age of Artificial Intelligence, where it worries about the losing of the glorified aura of the physician, the godliness of the physician in diagnosing the thing, diagnosing the patient. But what my take is, technology will not replace doctors, but doctors who use technology will replace those who don't use technology. Thank you.
Very well said, very well said. This is what is actually the mantra. Digital healthcare evolution has to come for smart medicine, precision medicine, but that doesn't nullify the empathy, that doesn't nullify the contribution of the doctors to the society, and the societal structure between the doctor and the patient should be above of any technological evolution and intelligent healthcare system. So thank you, Dr. Arun, for nice deliberation. I just would like to now introduce the extreme left of my Mr. Peter Frederick. Peter Frederick is the founder and developer of Sumit Barger pneumatic tube system. I just would like to give a small introduction, sir. It is one of my favorite topics because long back when my city, Kolkata was just seeing the, you can say, automation in the laboratory care. And that point of time, we took a step from the ICU to the laboratory. We wanted to have time periods less by introducing the pneumatic system. I'm talking of CK Birla Group of Hospital. We did it in BM Birla and CMRI. And we had a very successful activity because for that reason, the entire treatment part for the patient came down to less than 4 hours. Because initially it was 8 hours time, all the samples used to go by the GDA, the people, peon type people used to carry the sample from different parts of the hospital to the lab at night time particularly. So this really solved our problem. Later on we tried with the blood bank also to send the blood bank, but that didn't come out that so easily. I don't know, I'd like to hear from sir today to whether also the blood bank can be successfully transported from one place to another place, particularly to the blood bank with the requisition. That would like to hear from you, sir. Please.
I want to. So thank you so much for this perfect introduction of the system. I just looking for the, it's here. Yes, so yes, smart pre-analytic workflow, that means your blood sample one touch at the point of care and deliver it directly to the lab, and the result is sent back to the nurses immediately. As you already introduced, time is very critical in hospitals, and this kind of systems are helping a lot to reduce the turn time of the workflow. So we are a company specialized in the pneumatic transportation and workflow of samples in the hospital, and especially we are now focused on the pre-analytic workflow. That means sending the sample to the lab, going into the lab through the lab gate, and you have the first check-in of the sample. That means you get exactly if there is any leakage on it, or the samples arrived in the lab, because mostly they are tracking and say, okay, where is my blood tube, and I'm not getting any result. So that's what we said, okay, what is important for the nurses, we are delivering. So we deliver the sample to the lab, have that lab gate for the check-in, and immediately the nurses are getting back the what kind of samples are already in the process. So this is one of the patents of Summitsberger, we call it lab gate. So there are two possibilities, to deliver and to distribute. So we can solve both problems, that especially also to the Siemens Healthineers, we also deliver the samples, we check them in, we deliver the samples directly in your automation, and Siemens Healthineers are delivering the results to the nurses. So that's shake hands in between, and saving a lot of turnaround time in the hospital. So this is smart intelligent sample dispatching system. That means we are already controlling the samples from the point of care. We are scanning the samples. We have RFID tags in our system so that we can control the transportation up to the lab. In the lab gate, we have a reader of the sample, and we read already the carrier again, we double check, and we have the full traceability of all our transportations. This we are not only using for the blood tubes, we are also for medication and also for blood bags or infusion bags. So that the lab gate can be extended, that you say, okay, we get it in, we have the check-in, we get the sample results, and we sort them already out into different boxes and then make a manual handling, because not all the labs in the hospitals have a full automation and a full lab automation system. So they can also use this in small hospitals, that they just check in the samples and get in already the information to the nurses. There is also included the first pre-analytic check. So we are checking the barcoding, we are checking the color coding, and we can see a 360 degrees picture we put into a database, and if there is any concern happening on the blood tube analysis, we can already track the sample back and get the picture of the sample and see if there was something wrong on itself. So that's a big advantages, and this is also possible with a connection to the nurses, and the nurse itself is also able to track the sample. There is no patient information on it. It's just a number coding, and you can access to your blood tube samples to the lab, which has been received already. After receiving the samples, we have a new innovation that's called disinfection gate. So we sending the sample in a UVC gate, and we have a testing report after 20 seconds that all this virus or others is already solved, and we are sending back this carrier back to the point of care. And this is a new innovation, especially from critical areas, that you send the carrier into the lab. Nobody is touching any sample. It's unloaded. It's going into the process. The carrier goes into the disinfection gate and comes back to the station as a full disinfected. So for sure you can add to these pre-analytic sorters and smart distribution systems. And yeah, there are some samples where you can see our installations. We can connect to all the major blood sample companies and bring the blood tubes directly into the process. So I have to start the video now. Face. Okay, so there would be a short video on it, how it works and how it's soft transportation, because it's not only the process itself, also our high sophisticated modern BTS system is also able to control the transport speed and have a soft landing function inside. And also we are using a HEPA filter on the blowers, that we are filtering the air which we are blowing into the nurse stations, or we are sucking the air from the nurse stations. So this would be on the video. Here you can see lab gate samples. As I already told you, Siemens is the first one. You can see it's in Aarhus in Denmark. Is a very big installation from your side. It's one of the most modern hospitals in Europe. And they are using this implementation of the lab gate since already 2-3 years, and they are making around 5,000 transactions every day. So we can connect to all the major players. And yes, as a summary of all, when you are using this kind of systems, you have the transportation, full traceability, the result of the sample landing in the lab, and the nurses can track and trace all the blood samples in your hospital. So this is just to show our organization. So you see, we are operating in 105 countries worldwide and have around 15,000 installations. So thank you for listening. And
Thank you, Mr. Peter. I mean, everybody knows that for a fully automated laboratory system, pneumatic system has to come. Without that, you cannot have a total control on the automation of the laboratory system. So I would request now my co-moderator, Mr. Venkat Phanidhar, to have the concluding remark.
Thank you, Dr. Sen. After Dr. Paul's talk, I think sitting for a longer time is new smoking. So let me stand and conclude the session. So my dear friends, after his speech, I would like to, something comes to my memory. I had the opportunity to install the first pneumatic chute system in a hospital where I worked. Okay. And it was really helpful, and as we are the first to implement it in Tamil Nadu, so my chairman was so passionate that he used to bring a lot of guests to show how it works actually. I don't know, like a pre-programmed thing, the intelligence of the system is so, it works fantastic all the time. Only when he brings some guests and want to showcase, it doesn't work. Okay? So anyway, having said that, my dear friends, as we conclude this wonderful session, let me tell you one thing. In healthcare, intelligence without execution is just data. And that is what we have been practicing all these years. Yeah, you can clap. And let me also say that having said that, human judgment and compassionate care are irreplaceable in healthcare, whatever be the level of technology that we are going to adopt and bring into the healthcare systems. To align with this conference tagline, touch, tech, and trust. Let us not forget the touch of compassion. Let us try to adopt whatever technology comes our way, and let us build a strong trust among our stakeholders. Thank you so much. Thank you, speakers. Thank you, sir.
Thank you so much. We request all our speakers to please come together for the photograph now.
Assembled near the stage.